Hi, good evening, friends. I'm back. Yesterday, there was a skill transfer lecture, so I was not giving the lecture yesterday. Today, happy Bihu, happy Sankranti, happy Pongal, and happy Lohri. Today, I have come up with a new topic on the request of PG from KMC Manipal, Dr. Deepa. And this is very important for us. It's very, very prevalent in India. That's what I hear from many colleagues. That is tuberculosis of the genital tract. Genital tuberculosis is still a challenge. So I thought I must deal with this. And this can be a big question or a short note in the exams. Also, I have given many lectures on how to make a better presentation, wherein I say that there should not be more than 6 lines, and each line should not contain more than 6 words. With this lecture, I have tried to experiment a little bit more, and that is, I have tried to have at least just 3 lines only and 3 words in a line. I hope you appreciate that and like it as well. To dig a little bit into history, it is 1744, Morgagni first described this problem. And in 1834, it was called tuberculosis because they saw tubercles. It's only in 1882 that Robert Koch isolated this microorganism, that is the bacillus, and thereafterwards we have improved leaps and bounds. Once upon a time, tuberculosis was considered something like cancer or something like corona, where there is no cure for it. Now we talk about cure for tuberculosis. Genital tuberculosis is the third most common extrapulmonary tuberculosis. Second being the lymph nodes or lymphatic system. So it is important for us to know this. Incidence, not uncommon, I would say. At the same time, not very common as well. This is the tricky language that is used in most of the textbooks to say one which is not very common, at the same time not very rare, not uncommon. 1 to 19%. As you can see, the incidence varies from place to place depending upon the endemicity of it. Whatever it is, in infertility, you can see at least in 5% of the cases, tuberculosis. But some of my colleagues, some of my students tell that up to 21% they have seen. Some of the literature, Indian literature says 21%. Some centers even claim 50% of their cases of infertility are tuberculosis. It may be the case in a particular area. Pathogenesis, almost always secondary to tuberculosis elsewhere. The primary genital tuberculosis is very, very rare. It may be 25 to 60% from miliary tuberculosis, 2 to 20% from pulmonary tuberculosis. But it takes around 20 years after pulmonary tuberculosis, because as I said, the spread is from hematogenous and it will take a long time. Spread, just now I said it is hematogenous. It can be lymphatic as well, because I told you the second most common site of tuberculosis is lymph nodes. It can be lymphatic spread as well. There can be a direct spread, including sexually transmitted. So that's how tuberculosis comes to genital tract. Mother to child transmission, vertical transmission, what we call, is rare. Risk is reduced further by taking antitubercular drugs. And all of us know ATT is not contraindicated during pregnancy, including first trimester. And we must give that. The risk factors increase if it is EP or miliary tuberculosis or meningeal tuberculosis. What is the nidus of genital tuberculosis? Fallopian tubes. I hope by this time you have also noticed that it's not just 3 lines or 3 words sometimes. I have changed the font size also. This should tell you indirectly that the bigger the font size means more common. Lesser the font size and change of color means less common, less important. Fallopian tubes is in the biggest font. Then other pelvic organs, the font is smaller and the color is gray. That means it is not so common. Peritoneum, I have further faded the color and changed the font to smallest one. So it's not so common. To give you exact frequency, fallopian tubes 90 to 100%. In fact, it comes from there into the endometrium, 50 to 70%. Then comes ovary, 20 to 30, cervix, 5 to 15%, and vulva vagina, just 1%. So fallopian tube is very, very common nidus of the genital tuberculosis. And unfortunately, that's the most important organ as far as fertility is concerned. And that's where it will hit us badly, because from there it can go to endometrium and can destroy the endometrium, the 2 important organs that are required for fertility. It includes ovary as well, as you can see there. And with the TO mass, it can further reduce the chances of fertility. Pathogen, of course, it's not a secret at all. Mycobacter tuberculosis, 95% of the time. Bovis, Africanum, and Microti also are possible, but less than 5%. What's the pathology? Polymorph exudate is the commonest form of pathology that we can see, but later we can see even caseation necrosis in the center. Granulomatous lesion is the one which pathologists diagnose as tuberculosis. Types, exudative type, mostly seen as pyosulfings. Adhesive type may be tubercles or adhesions in the pelvis, in the uterus, as uterine synechiae, Asherman's what we call. In the endometrium, it is usually extensive at the fundus naturally, because the spray is coming from the tubes. Tubes being the commonest site of tuberculosis. And from there it comes to the fundus, usually that from the cornual ends. So it is extensive at the fundus. So if you are doing a EB, you must curate the fundal region to get a good culture. Myometrium is surprisingly not involved, but it doesn't matter. Endometrium is more important for us. And if endometrium is involved, it is destroyed and there's no implantation. Reinfection usually occurs from the tubes again. As I said, tube is like a storehouse of tuberculosis. It will keep spraying from the cornual ends, especially if there is pyosulfings. Ulcers can be seen in endometrium. Fungative lesions also can be seen. Intrauterine adhesions, as I just now mentioned, synechiae, and there can be total destruction of the endometrium. And if it happens, there is no way you can improve it. No drug, no amount of estrogen is going to rebuild this endometrium. It's gone forever. What's the presentation? It can exist without any clinical manifestations. That is the problem with genital tuberculosis. In pulmonary tuberculosis, patient will cough, cough and cough for weeks together, and you can easily make out. In lymphovascular or lymph node tuberculosis, you can see big lymph nodes and you can easily take a biopsy from that and find out. The manifestation can be very, very minimal. Sometimes it may be menorrhagia. Sometimes it will go to the other extreme of amenorrhea when the endometrium is totally destroyed. But in some patients, there won't be any manifestations. And by the time you detect genital tuberculosis, it will be very, very late. Those who present mainly as cases of infertility, 40 to 76% of the cases. Others may come with a tumor mass, and because of the stretching, there can be pain. As I said, the main menstrual problem that you can see initially, hyper, then oligo, and finally amenorrhea. So hypermenorrhea in the beginning, when there is inflammation going on, then once the endometrium gets destroyed, there would be oligo and finally amenorrhea. Please recall what I taught in primary infertility and secondary infertility. Tuberculosis blamed both in primary as well as secondary infertility, though primary is rare, but secondary amenorrhea, tuberculosis is very common. In primary amenorrhea, tuberculosis is not that common, but it can still occur. What are the signs? Normal findings in up to 50% of the cases. Uterus is normal size, ovaries may be normal, even though the tubes are having some problem or infection there, usually unless there's a big biosulfings or hydrosulfings, you can't palpate the tubes. And there's no evidence on the cervix or in the vagina. There is no tenderness. Very difficult to diagnose genital tuberculosis just like that. Unless you have a bent of mind, unless you have a reason to suspect genital tuberculosis, unless it's an endemic area, it's very difficult. It's by a high index of suspicion, or you're treating a case of PID, not getting cured. You're treating a case of infertility. All the other investigations are normal. Then you suspect tuberculosis. Those who have got signs, it is because of TO mass. There's an adnexal finding, that is the TO mass. Ascites can be there. Usually it is loculated ascites. So again, very difficult. It may not be a huge ascites to pick up a case of genital tuberculosis. Ulcer, yes, if it is there on the cervix, we can easily make out, but nowadays that's not seen that commonly. It can mimic carcinoma cervix or ovary. The ulcer may have sometimes punched out edges, and you may wrongly diagnose it as a case of carcinoma cervix on visual inspection. Similarly, in the ovary, incidentally, when you do a laparoscopy, you may find that the surface area may be breached and you may wrongly consider it as ovarian cancer. Other pelvic lesions also may coexist in tuberculosis. There may be adhesions, there may be endometriosis, there may be other evidence of tuberculosis and PID. How do you diagnose? This is the most difficult part about genital tuberculosis. When the signs are so few, when the symptoms are not there, it's only high index of suspicion to start with. Where do you suspect them? In endemic areas, as I already said. If there's a family history of either pulmonary tuberculosis or genital tuberculosis, or if the same person had extra genital tuberculosis in the past, maybe 20 years ago, maybe 30 years ago, as we saw in the first slide, from pulmonary to genital, it takes almost 20 years, especially if the treatment has not been very consistent and good, or if there has been resistant strains, or if the patient later develops HIV. So these are the situations tuberculosis will come back like a phoenix. Unexplained infertility is another reason where you suspect tubercular endometritis, as I just mentioned earlier. you have done all investigations, hormonal investigations, everything is normal. Then you start thinking about tuberculosis. You take a X-ray, or because of HSG, you will find the findings in the tubes. And you realize that on hysteroscopy, the endometrium is bald. Suspect tuberculosis. Or there may be synechiae. Suspect tuberculosis. Unresponsive PID, as I said, you have given the usual course of antibiotics. Whatever regime you follow, it's not responding. Maybe it is tuberculosis. Again, in adolescents, TOMAS, especially those who are not having any sexual activity, the hematogenous spread from the pulmonary tuberculosis must be the cause of this TOMAS. Otherwise, she is sexually not active. Suspect tuberculosis. Ultrasound, as I said, if there's a TOMAS, it is not possible to miss this. Ascites, as I said, it is usually loculated because of the adhesions. You may sometimes confused with a multiloculated ovarian cyst. You have to be careful. Thickened endometrium in the initial stages. Thickened omentum in the ultrasound. But later stages, thin endometrium, no triple line, no nothing, no amount of estrogen is going to help this. HSG, as I said, there are a whole lot of findings. Rigid, beaded tubes, distal saculations, or hydrosulfates. Very, very obvious. There are many, many more types of tubes that are described in tuberculosis, but the common ones are lead pipe type of tubes, beaded, isthmic or nodosa, what we say, distal saculations like tobacco pouch, or obvious hydrosulfates. Laparoscopy, we don't do to diagnose tuberculosis. Let me repeat. We don't do laparoscopy to diagnose tuberculosis. In fact, you should not do it because it can go disseminated. If you know or if you suspect tuberculosis, don't do laparoscopy unless you have given at least 6 weeks of antitubercular treatment. Then why have I put it here? You have done laparoscopy for some other reason. Maybe you were suspecting endometriosis. Maybe you were suspecting PID. Maybe you are suspecting some adhesions you wanted to adhere your lysis. Then you will incidentally find tubercles on the organs. I hope I'm very, very clear. You don't do laparoscopy ab initio to diagnose tuberculosis. It is usually an incidental finding. Adhesions you can see. And that's how laparoscopy, hysteroscopy, X-ray, ultrasound will help you. What are the hysteroscopic findings? Again, you are not doing hysteroscopy to diagnose tuberculosis. You are doing hysteroscopy as a routine pre-infertility evaluatory method. You will see adhesions. You can see scarring of the endometrium. You can see bald endometrium. Now comes the lab. All your findings, ultrasound, X-ray, or even your direct visualization, they are all only indirect evidences. You have to prove tuberculosis. So what are the lab investigations? Routine lab studies are of little value. ESR is raised. ESR is raised. 128 causes will be there for that. Not just tuberculosis. Tuberculosis is one of those 128 causes. So routine lab investigations are of no use. Even old tests like tuberculin test, Montu test, I think many centers have given it up. No point in doing. It will only just reaction. It doesn't say anything much. Chest X-ray, unless the patient is coughing like anything, unless you find that a big cavity there, it's not a good test. ZN staining, yes. If you are very lucky, go ahead and do. Fluorescent technique, of course, again, you have to be extremely lucky to see this tubercle bacilli. What are the other tests? Interferon gamma release assays have come, but these tests are not very popular. There's something called T-spot or TB test, T-spot. But biochemical tests, whenever you feel there is ascitic fluid, you can take that and send it for biochemical analysis. If there's adenosine and deaminase activity present, it is highly suggestive of tuberculosis because it is very specific and sensitive. But CBNAT, cartridge-based nucleic acid accentuation test, which detects DNA in TB bacteria. The sample is endometrium. Time taken is less than 2 hours. This is the most popular, current, and the best test that we have. CBNAT can also detect mutation. It does not replace, however, the need for AFP smear and culture. Of course, any microorganism, bacteria, culture is the final proof. Something like for any cancer, biopsy is the final proof. But we all know that culture has got its limitations in especially tuberculous bacilli. It will take a long time, but then we have got better media now. So all I'm heading towards is the gold standard, that is MTB in culture. Backtech here again, like CBNAT for the nucleic acid DNA detection. Backtech is the better culture media, 7H12 broth. It detects in 1 week compared to the old LJ media, 3 to 8 weeks. So liquid culture rapid is the one which we use nowadays, Backed Alert 3D MB. Culture specimen, you can actually send endometrial biopsy, which is the best. When you take that biopsy, as I said earlier, go towards the fundus, maybe towards the cornea. That will give you the better yield. Menstrual blood also can be sent sometimes because, this, wherever you cannot get an endometrial biopsy, you can even send the menstrual blood of the day 1 or maybe sometimes even the second day. Peritoneal fluid also can be sent for culture and specimen. So best is, of course, endometrial biopsy. As you can see here, it is in the bigger font, black color, menstrual blood, smaller font, gray, and peritoneal fluid is lighter color. Histopathological examination may be too late, but pathologists can diagnose when they see epithelial granuloma. PCR, I want to clarify this because many gynecologists, they depend upon PCR. What is the truth about PCR? No data on reliability and reproducibility. I searched high and low, superficial as well as deep. False positive rates are 20 to 70% because it can even find out the dead bacilli. Positive even after ATT. So do you want to trust that and treat your patients? What's been told as early as 1995 is that based solely on PCR, we should neither start nor stop treatment. I don't want to say anything more. What about serology? WHO has clearly told us in 2011 itself, it should not be used. So culture is the gold standard. You can do ZN staining. You can better do CBNAT, which will give you result in 2 hours. What is the positivity rate? Smear, as I said, very low yield, 12 to 3%. That's why I said you should be lucky to isolate, even with fluorescent technique. Culture, though gold standard, look at this, 18.4% only. Histology, too late, but better because they can see nice tubercles there, 26.1%. CBNAT, 45%. So that's why I was telling CBNAT is better. And not only just that, It gives you result in 2 hours. Culture, even with the back tech, it takes 1 week. What's the differential diagnosis clinically? Hepatitis, cholecystitis, ovarian cancer, because as I told you, it may look like one. With ascites there and a mass on the ultrasound, you have to consider ovarian cancer. Appendicitis, especially if the mass happens to be on the right side. Histopathologically, whole lot of differential diagnosis. Sarcoidosis, Crohn's disease, actinomycosis, leprosy, granuloma inguinale, lymphogranuloma venereum, syphilis, brucellosis, silicosis, all the best. Thankfully, we are gynecologists. It is for pathologists to tell us which among them it is, or none of them, it's just tuberculosis. Complications, as I've been telling right from the beginning of my talk, infertility, up to 50% of the cases, both because of the destruction of the tubes as well as endometrium, and also ovary. What more you want? Ectopic pregnancy, because the tubes are destroyed, tubes are kinked, maybe adhesions, 45%. Abortion, because the implantation, though occurs very rarely, it's not a successful implantation. They may go for abortion due to avascularity there in the endometrium, 35%. What's the management then? Do we have any management at all? The damage to the tubes and endometrium is often irreversible. Look at the font size I have chosen. It suggests that once it is gone, it's gone forever. You better remove the tubes. Otherwise, there's no chance, even if you want to do IVF. And even if you did that, the chance of implantation and successful acceptance is very, very rare if the endometrium is destroyed. Probably surrogacy is the only answer. You can use her own eggs if the ovaries have been good. So, chance of successful pregnancy drops significantly. As you can see here, pregnancy rates in different studies, Tripathi, SN and all said 2 per 165, 0.01%. Other studies said 31 out of 7,000, 0.004%. 0%. So very, very difficult once it is already destroyed. Management is only to alleviate pain and menstrual disorders. Medical management. Infertility, very difficult to treat. Regimens, same as pulmonary tuberculosis. INH, rifampicin, ethambutol, PZA for 2 months. You may add streptomycin in a high rate of resistance instead of any one of them. After 2 months of 4-drug regime, you can switch over to just 3 drugs, that is INH, rifampicin, and ethambutol for 4 more months. It's very standardized now. Gone are the days where you would give for 9 months and all that. It's just for 6 months. You may add pyridoxine, 25 to 50 milligrams daily, because INH is going to destroy, it's going to affect the liver and vitamin B complex deficiency. So that's why you may add this. So it's popularly called 2 months of HREZ and 4 months of just HRE. That is INH, rifampicin, and ethambutol. MDR cases. What is MDR? Multiple drug resistant cases. You can choose other drugs like cycloserine, kanamycin, thiacetazone, amikacin, levofloxacin, ciprofloxacin, and ofloxacin, para-aminosalicylic acid. These are the drugs that are used for multi-drug resistant cases. You have to simultaneously treat maybe sometimes HIV. So before ATT, it is better and mandatory sometimes that you do universal drug susceptibility testing. For that, you may still use CBNAT. For rifampicin, line probe assay as a first line drug, that is INH, line probe assay for second line drugs as well. so that you don't unnecessarily give a drug which is resistant. Follow up, of course, by endometrial biopsy at the end of the treatment, then every 6 to 12 months. What is the surgical treatment? Only if there is a big mass, or there is a persistence or recurrence, or there is multi-drug resistance, or if there is concomitant malignancy. It looks like malignancy is one thing, having concomitant malignancy is another thing. What's the surgery? You may do bilateral salpingectomy. As I said, once there is hydrosalpinx, there's no point in rearing that tube there. It's useless. It will cause other problems, ectopic pregnancy and things like that. It may even disturb the implanted ova through its secretions there. Bilateral salpingectomy. BSO, if there is a TO mass, no point in keeping that ovary as well. Remove that, otherwise your antibiotics may not work. Of course, you have to go for donor egg as well as for surrogacy, maybe in this particular situation. THBSO is a last resort sometimes. You may have to remove if the tuberculosis is so rampant there in that particular case where uterus, tubes, and ovaries all are infected. So what's the carry-home message? Tuberculosis of genital tract is not uncommon. You have to have a high index of suspicion. Tubes and endometrium are the commonest to be affected. Of course, endometrium gets affected from the tubes. It may be asymptomatic altogether. That's why I said you have to have high index of suspicion. If at all, they may present just like AUB, initially hypermenorrhea, later oligo and amenorrhea. Those cases, after they marry, they come to you as infertility in up to 50% of cases. CBNAT is the most popular and the best used test. Of course, culture is the gold standard. Fine. For that, instead of Stephen Leventhal medium, you may use BACTEC, which gives you result in probably earlier 1 week. The treatment, of course, for 2 months, 4 drugs, HREZ, and followed by 4 months of HRE. All said and done, the pregnancy rates are very, very poor if the endometrium is already destroyed. However, you must still treat it because you cannot allow it to spread. There will be other complications. You have to relieve the pain, and you have to also relieve the other complications. It needs long-term follow-up, though the treatment is for 6 months. Every 6 months, you have to do endometrial biopsy. So thank you very much. I hope you liked this topic, and I hope you understood this very clearly.